Welcome to the Skeptic's Guide to Emergency Medicine. Meet 'em, greet 'em, treat 'em, and street 'em. Today's date is March 11th, 2026, and I'm your skeptical host, Ken Milne. The title of today's podcast is Close Enough for ARF, Acute Respiratory Failure, High Flow Nasal Oxygen, or Non-invasive Ventilation. And our guest skeptic is Dr. Rory Spiegel. He's an emergency medicine and critical care physician known for his work in evidence-based medicine and critical care. He is widely recognized for translating emerging research into practical bedside insights through lectures, writing, and digital medical education. His work focuses on resuscitation science, airway management, and the critical appraisal of the medical literature. Welcome back to the SGEM, Rory. It has been just too long.
Too long is right. I'm trying to think when we were shared the space together.
I think it's pre-COVID.
It was definitely pre-COVID. I think it might have been like 2016 or 17, something pretty far back.
Were you at SMAC in 2019 in Sydney?
No,
okay,
I wasn't there.
I think
the last SMAC I went to was Chicago.
Yeah, I remember being in a small room with you teaching sensitivity and specificity to people.
Yeah, and then we had that debate. We had the debate about evidence-based medicine.
Yeah. That was Chicago SMAC. Bringing back memories. Well, a lot has to have changed since then. What have you been up to? Where are you practicing? What are you doing?
So, I think since last we talked, I finished my critical care fellowship, and I now split my time between emergency medicine and critical care, 50-50. I work at Washington Hospital Center, which is the big receiving hospital in the Georgetown University kind of health system, and just enjoying it.
Staying busy.
Yeah.
Well, I don't want anybody to feel sympathy for me right now. You might notice by the audio, there's some birds chirping in the background, waves lapping up to the shore and the sand, because I'm in Maui at the Center for Medical Education Year in Review course. And this CCME has been doing courses for, I think, almost 40 years now, Rory. And these courses take place in the most amazing locations all throughout the U.S. I mean, I'm in Maui now, but there's a course going on in Vail right now, Hilton Head, Key West, New York City. I mean, it's amazing. And the CCME faculty that gets recruited are some of the best and most outstanding educators out there. And we look through 260 articles. So in the past 2 months, I have gone through 260 plus articles that were published in the past year. And it's really unique, this course, Rory. You're a medical educator. You might like this. No PowerPoint slides, no PowerPoint karaoke. There's just you, a fellow co-presenter for each half-hour lecture, and the attendees. There's nothing between you guys. And it's really good. And you take about 8, maybe 9 publications on cardiology, let's say. And in that half hour, you have this direct interaction with the attendees, and they have it with you as the speaker. And I really, it's like, if you remember the MTV Unplugged, it's acoustic. It's just you and the audience and the literature. I love doing it.
Yeah, I mean, that's the way it should be. I think, I think the reason it's not done that way more often is because the knowledge that one has to possess to be, and the skill to do that, is just far beyond what you need to do to kind of recite a PowerPoint.
Like, as the faculty, we have 4 faculty at each of these courses, 260 articles. You don't have to read all the articles. You have to read the ones that you're the primary on and the ones that you're co-presenting. Yeah. So let's say 120, 130 articles.
Only 130. It's not so much.
But Rory, you know me, I read all of them. Oh yeah, I read all of them. I did a deeper critical appraisal on the ones I'm taking the primary and the secondary on. And, the other ones, I read them, and, you can just go to the method section and go, is there something here? Or is this a nothing burger once you've been doing this long enough? But I read all of them.
Well, that obviously a lot of work, but then you end up on a beach in Maui.
Yeah. And I feel like I'm up to date on the latest literature, and that I've got a big swath of what's out there. And then we refer back, of course, because the faculty have decades of experience, and they may have picked up something that I missed. Also, we have the wisdom of the attendees, because there's always somebody out there that's smarter than you on that specific subject. And we had that yesterday when Phenobarb came up for talking about alcohol withdrawal. and comparing to benzos on one of the papers and talking about the real nuances from an ICU perspective. Hey, this stuff's going to last for days, versus the ER doc's perspective, talking about, well, we're using benzos traditionally, but now we're getting all this information. Maybe we should be using phenobarb because of these certain advantages.
Yeah, I mean, you're speaking my love language. I spent the last 3 years rolling out a phenobarb protocol for our hospital system, both ED and system wide.
So if people want to stay up to date on the most recent literature, interact with some really great faculty, and come to some really nice places, I'll put a link in the show notes to where the courses are this year. But Rory, why don't you get to a case and let's talk about this whole high flow nasal oxygen and non-invasive ventilation.
So our case is a 64-year-old woman with a history of COPD, gold stage 3, hypertension, and presents to the emergency department with worsening shortness of breath over the past 24 hours. She reports an increased sputum production and wheezing. On arrival, she is tachypnic and speaking in short phrases. Her vital signs are a heart rate of 104 per minute, blood pressure of 148/86, a respiratory rate of 30, a saturation of 88% on 4 liters nasal cannula. On exam, she's using accessory muscles and has diffuse wheezes on auscultation. When you look at her ABG, it reveals a pH of 7.29, a PCO2 of 58, and a PaO2 of 62. Her chest X-ray shows hyperinflation without focal consolidations.
So she's not looking good, right? I mean, this is the end of the bed. She doesn't look that great, does she?
No.
All right, so acute respiratory failure, or ARF, is one of the most common serious respiratory problems managed by emergency physicians, and you do both. You also do critical care. And for decades, the non-invasive ventilation approach has been the central part of therapy for selected patients. And this is particularly true for those with chronic obstructive pulmonary exacerbations and acute cardiogenic pulmonary edema. By delivering positive pressure, non-invasive ventilation reduces the work of breathing, improves oxygenation and ventilation. This intervention has been shown to reduce intubation rates and mortality in specific populations. However, non-invasive ventilation can be poorly tolerated, requires a tight mask seal and monitoring, and it's also resource intensive. These downsides can become more problematic if you've got a patient with a disease state that's not readily reversible over a few hours.
Yeah, I mean, I like to say high or non-invasive is great for short-term problems, but as the need of it kind of goes over the 6 to 8 to 10 hour, the logistical cumbersome nature of it just makes it more and more troublesome. The mask starts to really hurt. You need to actually start to kind of offload the pressure, and then the patients can't really eat or drink on it, so you start to deal with dehydration and so forth. But high-flow nasal cannula has emerged over the past decade as an attractive potential alternative. By delivering heated, humidified oxygen at high flow rates, high-flow nasal cannula improves oxygenation and, more importantly, improves ventilation by reducing the dead space. It's often better tolerated because the patient doesn't have to wear a tight-sealing mask. Its physiology appeal has led to widespread adoption, particularly during the COVID-19 pandemic. And yet the enthusiasm has sometimes outpaced the evidence, and important clinical questions remain. Is high-flow nasal cannula equivalent or non-inferior to non-invasive in preventing intubation or death? How does it perform across different types of respiratory failure? And when should clinicians choose one over the other?
Yeah, we do get a lot of enthusiasm when we get a new toy or a new tool to use in medicine. And so sometimes we can get over our skis, as we say on the hill. The enthusiasm outpaces the evidence.
That's a very Canadian phrase.
Isn't it? Yeah. So, Rory, what's the clinical question we're going to try to answer today?
Is high-flow nasal cannula non-inferior to non-invasive ventilation regarding the rates of endotracheal intubation or death at 7 days across 5 distinct patient groups with acute respiratory failure?
And what's the reference we're looking at?
So this is the Renovate trial. It was published in JAMA in March 2025.
All right. And so let's go through the PCOT. What was the population?
They included all adult patients hospitalized with acute respiratory failure And they defined this as hypoxia plus respiratory effort or tachypnea. And they divided these into 5 groups, the 5 subgroups. The first subgroup was non-immune compromised with hypoxia. The second was immune compromised with hypoxia. Third was COPD with respiratory acidosis. Fourth, acute cardiogenic pulmonary edema. And the fifth was hypoxia with COVID-19.
Yeah, and they had a number of exclusion criteria, but the main exclusion criteria was if there was an urgent need for endotracheal intubation, the patient was hemodynamically unstable, or there was some contraindication to using the non-invasive method. What was the actual intervention they used?
So they used high-flow nasal cannula, which was delivered continuously and titrated towards 60 liters per minute. And this was compared to non-invasive ventilation delivered through a face mask.
Okay, let's go through their outcomes. What was their primary outcome?
They had a composite outcome of either endotracheal intubation or death within 7 days.
And so you could argue one might be more patient-centric or more about the patient-oriented outcome, or the POO, dead or alive, versus endotracheal intubation, which would have some subjective nature, and maybe patients would be less concerned about, having a plastic thing put down their throat, compared to whether or not they were alive or dead. But they put those two things together. How about the secondary outcomes?
Secondary outcomes was 28-day and 90-day mortality, mechanical ventilation-free days, and ICU-free days.
And from a methodological standpoint, what type of study was this?
All right, so this is a mouthful. This was the multi-center adaptive non-inferiority randomized clinical trial using Bayesian hierarchical model with dynamic borrowing across patient groups.
And we even shortened that a bit because we could have put unmasked or unblinded because people knew which group they were in. So, it's a mouthful, isn't it?
Yeah.
All right. So the author's conclusions were, quote, compared with non-invasive ventilation, high-flow nasal oxygenation met pre-specified criteria for non-inferiority for the primary outcome of endotracheal intubation or death within 7 days in 4 out of those 5 patient subgroups with ARF. However, the small sample sizes in some patient groups and the sensitivity of the findings to the choice of analysis model suggests that the need for further study in patients with COPD, immunocompromised patients, and patients with ACPE, end of quote. All right, let's run through the quality checklist for randomized control trials. Was this study population, did it include or focus on patients that were in the emergency department?
I would say include. Yeah, it was patients, the type of patients we see, and some of them were in the emergency department, but they were also recruited in the ED and the hospital wards, or they were also recruited in the ICU and the hospital wards.
And do you think the patients were adequately randomized?
Yeah, it was electronically permuted blocks.
And did they sort of conceal the randomization process?
Yep, central automated system.
And were the patients analyzed into the groups to which they were randomized?
They were.
And the patients, were they recruited consecutively?
Yes.
And when you looked at the both groups, were they similar with regards to prognostic factors?
It's a little unclear, but I think for the most part, yeah.
And were all participants unaware of group assignment?
No. So because of the nature of this being high-flow nasal cannula and non-invasive, it was pretty hard to blind both the clinicians and the patients.
And were all groups treated equally except for the intervention?
Hard to say exactly. It was protocolized care, but because of the open label design, it's unclear whether the clinicians' beliefs on one device versus the other changed their treatments and escalation.
And how about the follow-up? Was it complete enough?
Yes. I think 98% of the patients had full follow-up.
And all patient-important outcomes, do you think they were considered?
I think so. Yeah, I mean, I think sometimes this gets tricky, but obviously the question you're really asking here is how does each of these devices support people with their respiratory distress? And then you're using intubation and or mortality as kind of markers for whether it can do what you hope it does. And I think that's probably the best you're going to do with something like this.
And do you think that the treatment effect was large enough and precise enough to be clinically significant?
I mean, I think what we'll get into is no. It's a fairly large study overall, but because of how many subgroups they get into, it's pretty hard to make any like big decisions with these results.
Yeah, you sound unsure. How about the funding for the study?
So it was supported by a grant from the Brazilian Ministry of Health, Fisher and Bickel Healthcare providing the high flow nasal cannula equipment. The trial coordinating center and sponsor was HCORE Research Institute.
Yeah, and they actually put in there, quote, the funders, sponsors had no role in the design or conduct of the study, collection, management, analysis, and interpretation of the data, preparation, review, or approval of the manuscript and decision to submit the manuscript for publication. So they really tried to clarify, the role that the funder or sponsors had.
Yeah.
How about the investigators, though? Did they have any financial conflicts of interest?
Multiple authors report conflicts of interest. Most specifically, for this study, one author received personal fees from Fisher and Bickel, who are the makers of the high flow nasal cannula device.
And when we mention conflicts of interest, I always try to at least make an attempt to say that doesn't negate the findings. Conflicts of interest don't negate the findings. It just should make us more skeptical and scrutinize it maybe a little bit closer because of what we know about conflicts of interest.
Yeah.
All right, let's get to the results, though. So Renovate, which is the name of the trial, they randomized 1,800 hospitalized adult patients with acute respiratory failure across 33 hospitals in Brazil. So, a multi-center trial in Brazil. And they got 1,766 completing the trial. The mean age was 64 years of age. 40% of the participants were women. And the population was primarily older adults with moderate to severe respiratory failure. But the largest component of those 5 pre-specified subgroups, like almost half, consisted of patients with hypoxemic COVID-19, because this trial took place during COVID-19. So you've got to take that into consideration, that almost half of the patients included in those 5 subgroups, these were COVID-19 patients.
And I think even more specifically, this was early COVID-19. That was the initial disease, which, obviously has changed over the years.
And our understanding of how to manage these patients has changed also as well. So good point. How about the key result, though?
What they found was high flow nasal cannula was non-inferior to non-invasive for the composite outcome of endotracheal intubation or death within 7 days. And this was consistent over 4 out of the 5 subgroups.
And let's give some numbers. The primary outcome was that endotracheal intubation or death within 7 days. So what was the results?
So overall, out of the whole population, 39% of the patients in the high flow nasal cannula group and 38% of the patients in the non-invasive group experienced intubation or death.
And for non-inferiority, it was met in 4 of the 5 pre-specified groups. And I'm just going to be explicit about what those were. This was the non-immunocompromised people. They were non-inferior. COPD, ACPE, and COVID-19. What was the one group that they couldn't prove or demonstrate non-inferiority?
So this was the immunocompromised group, and it was stopped for futility, meaning they weren't going to reach a level where they could have proved non-inferiority. Now, if you look at the actual rates of death or intubation, in the high flow nasal cannula group, it was 57.1%, and in the non-invasive group, it was 36.4%.
Yeah, so an absolute difference of 20% there. So a number needed to harm, I guess, of 5 for endotracheal intubation or death. So you can see why they stopped that component of it. How about secondary outcomes?
They showed no statistical or clinical meaningful difference in 28-day mortality, 90-day mortality, mechanical ventilator-free days, ICU-free days. However, the subgroup-specific secondary outcomes were pretty imprecise and should be interpreted cautiously.
All right, I've waited years for this, Rory. I want to talk nerdy to you again.
Let's do it.
So we've got 5 points, traditionally 5, right? The first one is the diverse etiology. The authors enrolled all patients, so the consecutive patients coming in with hypoxic respiratory failure, which is great, and randomizing them to non-invasive support with high flow nasal oxygen or non-invasive ventilation. But using such a broad enrollment criterion led them to enroll a wide variety of clinical etiologies in the trial.
Yeah, I think this is the key to interpreting this trial. And, the advantage of such a broad inclusion criteria meant that the results can be applied broadly to basically all patients presenting to you with hypoxic respiratory failure. In this case, it's likely accurate to say that neither non-invasive or high flow is superior when treating an undifferentiated patient population with hypoxic respiratory failure.
Yeah, and these choices come with consequences, right? So if they chose one way versus the other way, and so a disadvantage is that the 5 subtypes of respiratory failure in this represent very different physiologic causes of acute respiratory failure, which may respond differently to different forms of respiratory support. There may, in fact, exist a potential benefit for either of these treatment options, the non-invasive or the high flow, in one or more of these specific subgroups that get obscured when you're looking and putting all these people together. And the authors address this by performing subgroup analyses for the 5 predefined subgroups. But unfortunately, due to the smaller sample sizes, because they're subgroups of the larger sample, these smaller subgroups, there were too few patients to really have confidence to demonstrate that the non-invasive support choice was preferable of one over the other.
Yeah, exactly. And it's these broad inclusion criteria make it really difficult to kind of interpret these results with any certainty, to really actually identify potential benefits of either non-invasive or high flow in any one of these subtypes of hypoxic respiratory failure. I think that the good example here is among the immunocompromised patients with hypoxia, where you see a pretty different point estimate in primary outcome. 57.1% in the patients in the high flow nasal cannula group versus 36.4% in the non-invasive group. As you said, a 20.7% absolute difference. But because of the small sample size, only 28 and 22 patients in the two groups respectively, it's pretty hard to say anything statistically with any certainty.
Yeah, and I think that's what we really need to nail home. You can't I mean, you can interpret this however you want, but I really think we need to be cautious of saying we've got definitive evidence, that we have non-inferiority here, when we really still don't know. And I think that would be an overinterpretation of the literature.
Yeah, exactly.
All right, let's talk about this lack of masking. And this is just a problem with this type of study. It's an open label study where the clinicians and patients knew which treatment group they were assigned. And this design can lead to something called performance bias. And this happens if clinicians adjust their co-interventions, supportive care, monitoring based on treatment knowledge. It may also cause something called detection bias, especially when with the outcomes that involve subjective judgment. For example, the decision to intubate a patient may depend in part on the clinician's assessment. And if the clinician involved believes, hey, I really think this is the treatment to go with, or conversely, I really think this treatment is less effective, they might escalate their care earlier, impacting outcome rates. And I don't want to hammer away on the authors about this. It's just a reality. When you've got a mask treatment versus a nasal cannula, you're not going to be able to set up a blinded trial properly.
Yeah. Yeah. I mean, a great example is like if you look how we use this in COVID-19 up in the ICU, the way we ended up pre-oxygenating our patients for intubation was non-invasive. And so, you were happy to leave people on high flow for longer because you knew you had non-invasive as your backup tool when you needed to actually move towards intubation. But if I was already on non-invasive and I was starting to have trouble, I'd probably pull the trigger earlier to intubate them just because I'd be really worried about what am I going to do for pre-ox when I have to do the intubation process.
Now let's get to the nerdiest point of all 5 nerdy points. And this is about dynamic borrowing.
Yeah, so dynamic borrowing, it's a fairly fancy term for something that I think is somewhat simple, which is essentially just borrowing patients from different subgroups to expand your N. And this trial used dynamic borrowing essentially allows data from one patient group to influence the results of another treatment group, as long as the effects are similar. And the authors utilized dynamic borrowing across all the 5 subgroups for acute respiratory failure. This means instead of analyzing each group separately, the model allows you to kind of shift patients from one subgroup to another to get a larger number of patients and improve your statistical accuracy.
Well, Rory, you're a super smart guy, and it might be really obvious to you, but it takes me time to get through some of these statistical approaches. And so I'm just going to add a little bit more context to that.
Yeah.
Dynamic borrowing, it is a statistical approach that's used in Bayesian hierarchical models where multiple related patient groups are analyzed together rather than completely separately. So you don't have this clean break of each of the 5 groups in this trial. And instead of estimating the treatment effect in each subgroup independently, The model allows the group to share data. And if a subgroup looks consistent, the model blends them slightly to improve precision, especially for smaller groups with less data. And if the results look very different, then the model reduces the amount of sharing. Now, this does improve statistical efficiency and stabilizes estimates in small subgroups, but there's a trade-off, and that trade-off is if there's a true difference between the groups that exist, dynamic borrowing can partially smooth them out and make subgroups appear more similar than they really are.
Yeah, I think that's such an important part. I think the other important part to note is when we're talking about similarity and dissimilar, we're referring to statistical similarity, or the similarity becomes the outcomes that we measured rather than clinical similarity, or the similarity in the physiological mechanisms underlying the respiratory compromise. And I think this is so important in this trial because we're basically taking patients with very different causes of their respiratory failure and applying two forms of non-invasive support that use fairly different techniques to support the patient. And so what we want to know is one of these techniques better than the other for this specific physiological compromise. And when we start borrowing patients from different forms of physiological distress, even if they look statistically similar, this might just obscure the results if one of these is better than the other.
Really important point. Yeah. Statistical similarity is different than clinical similarity, sort of like the difference between statistical significance and clinical significance. They're talking about the math here. Are they statistically similar as opposed to these two patients presenting with vastly different clinical presentations?
Yeah. And so the authors showed that using this statistical model can shift clinical interpretations, maybe not for the better. When they did a post hoc analysis where they basically took away their borrowing and analyzed the groups specifically to what physiological cause of their distress was, they showed different results than they did with the borrowing. Most specifically, for the acute pulmonary edema group and the immunocompromised group, there was a potential benefit for the non-invasive ventilation over the high flow nasal can.
Yeah, and I think when it comes to a lot of this nerdy statistical stuff, if you've got a treatment and that treatment has a pretty strong direction in one area, like it's moving you towards one direction, and it has a magnitude of effect size that's really big, and then there's a lot of precision around that, you don't need to do a lot of fancy statistics to figure that out. But yeah, maybe I'm just a simple country doc.
I think a lot of this trial was the fact that they knew because they had so many subgroups, they were going to have such small sample sizes for each individual one. And they tried to do a lot of statistical stuff to make up for that. But in the end, it's very hard to make up for that.
All right, let's talk about the whole concept of doing non-inferiority trials. As our friend Justin Morgenstern from the first 10 EM says, you don't understand non-inferiority trials, and neither do I. And these trials differ fundamentally from superiority trials because their goal is to demonstrate that a new intervention is not significantly worse than a standard treatment by more than a specific margin, which is referred to as the delta, the difference. And this margin must be clinically justified, and choosing the right value is crucial. If the delta is too large, it can lead to clinically important loss of efficacy being considered acceptable. On the other hand, if the delta is like too small, minor clinically insignificant differences may lead to a trial to be viewed as a failure. Additionally, analytic choices in non-inferiority trials can bias results towards the null hypothesis, often leading to non-inferiority conclusions. Therefore, it's good to be skeptical of these non-inferiority study designs.
Yeah, I think one of the problems with non-inferiority trials that's not often discussed is the statistical power, and that's somewhat pertinent in this trial because each of those subgroups were so small. But essentially, as the number of patients in the cohort dropped, the confidence intervals, or in this case, because it's a Bayesian study, the credibility intervals widen. And when this occurs, you can have a point estimate that demonstrates equivalency or even superiority of one treatment over the other. But due to these wide confidence or credibility intervals, the non-inferiority origin may still be crossed.
That's enough statistical stuff. Let's get back to the patient, because it starts with patient care and it ends with patient care for me. And so let's talk about this patient comfort. This was a secondary supportive outcome. And comfort was measured using a patient-reported scale reflecting how tolerant the respiratory support felt to the patient. This matters because non-invasive ventilation requires this tight-fitting mask that can cause claustrophobia, anxiety, pressure discomfort, air leaks, difficult speaking, you can't eat. And in contrast, high-flow nasal oxygen uses nasal prongs and is generally perceived as less intrusive. In the Renovate trial, high-flow nasal oxygen was associated with higher comfort scores, no surprise, than the non-invasive ventilation. And this is consistent with prior physiologic and observational studies suggesting improved tolerance. While comfort was not a primary or secondary efficacy outpoint, it is important to consider patients' preferences and values within an EBM framework.
Yeah, I think this goes directly to like the heart of the study and why a non-inferiority trial design was chosen. And the concept essentially is high flow nasal cannula offers other advantages than respiratory support over non-invasive, most specifically just comfort and logistical simplicity. As you said, they can eat and drink in it. They don't have to worry about the pressure of the face mask. And so the concept is what these also want to know, if it was found to be no worse than non-invasive, as defined by their non-inferiority margin, these other advantages may outweigh the small benefits that non-invasive provides over high flow nasal cannula.
Well, that was worth waiting for, those 5 nerdy points. I love talking nerdy with you, Rory. That was great.
It's been way too long.
All right, so let's comment on the author's conclusions and compare them to the SGEM's conclusions.
Yeah, I think for the most part we agree with the authors. I think one of the things here that's somewhat a shame is, before this trial was done, there were some holes in the evidence of where non-invasive was better and where high flow nasal cannula was better and what subtypes of acute respiratory failure you would want to use one or the other. But I think because of how this trial was designed and the small number of patients in each subgroup, I don't think we've really got any closer into kind of identifying where we should use one over the other.
Well, then give us an SGEM bottom line.
So this trial reinforces that high-flow nasal cannula and non-invasive ventilation both seem reasonable first-line strategies for many patients with acute hypoxic respiratory failure in the emergency department. It suggests that choosing high-flow nasal cannula for comfort and ease of application is unlikely to worsen mortality compared to non-invasive ventilation. Although the small sample sizes of individual subgroups make more precise conclusions fraught. In patient populations where prior evidence supports using non-invasive, like hypercapnic respiratory failure or cardiogenic pulmonary edema, these results are not robust enough to change your first-line choice of non-invasive support. The same can be said for high-flow nasal cannula in patients with pneumonia or ARDS. But what these results do support is being flexible and phenotype-driven rather than a one-size-fits-all for respiratory support. And it does suggest that using high-flow nasal cannula as an alternative tool in patients who are, for whatever reason, not tolerating non-invasive ventilation is a valid option.
All right. Can you resolve that case of that woman that came in not looking too good?
Yeah, so our patient with acute COPD exacerbation with hypercapnic respiratory acidosis, which places her in the group where non-invasive ventilation has strong physiological and evidentiary support as a first-line therapy. So the patient was put on non-invasive ventilation, or in this case BiPAP, reduces the work of breathing, improves alveolar ventilation, and corrects hypercapnia, and decreases the need of intubation and mortality in COPD exacerbations with acidosis. While the Renovate trial included COPD patients and suggested high-flow nasal cannula may be non-inferior overall, the evidence, when looking at its totality, still favors non-invasive ventilation in hypercapnic respiratory failure. Therefore, in this patient, we chose to use non-invasive promptly, along with bronchodilators, systemic corticosteroids, and appropriate treatment of any precipitating infections, reserving high-flow nasal cannula only if non-invasive was not tolerated or contraindicated.
So you've got this trial, the Renovate trial, 33 centers in Brazil, multi-centered and stuff. How are you going to apply it clinically in your practice?
Again, I think because of the small subgroups, it hasn't really shifted my thoughts on when to use high-flow nasal cannula versus non-invasive that much. I think we still go with the consideration that in patients where diseases that we can correct readily, hypercapnic respiratory failure, acute cardiogenic pulmonary edema, non-invasive is still probably your first-line option if the patient can tolerate it. And then when you have diseases where it's going to take longer to get them out of trouble, pneumonia, ARDS, so on and so forth, high flow nasal cannula is probably a more viable option.
So what are you going to tell this woman at the bedside when you're treating her? Because you're going to see her in the emergency department. You're not up in the ICU right now. You're going to see her in the emergency department.
So we're basically going to say we're going to use a specific mask that helps prevent having to put a large tube down your throat. And if for whatever reason you're having trouble tolerating that mask, we can switch to another device that kind of blows humidified oxygen through your nose.
All right, it's time for the Keener contest. And last episode's winner was Riker Keel from Wyoming. He knew that according to a study from Alberta, the factor associated with the largest relative increase in ED length of stay for admitted patients was inpatient capacity issues. Rory, what's the question this week?
All right, so the question this week is, what is the primary physiological mechanism by which high-flow nasal cannula reduces the work of breathing?
And there are multiple mechanisms, but we're looking for one of the primary physiologic mechanisms that help reduce the work of breathing with high-flow nasal oxygenation. So if you know the answer, then send an email to me, thesgem@gmail.com, with Keener in the subject line, and the first correct answer will receive a shout-out on the next episode. We have covered the issue of non-invasive ventilation and high-flow nasal oxygenation a number of times, and I will put those previous shows in the show notes so people can click and go back and look at those. But Rory, what a great experience to have you back and catch up.
Yeah, it's always a pleasure and an honor. I've been waiting to be invited back, and so it was exciting to get your email.
Oh, well, it's great to have you back. So you remember the what we do right at the end. So if you could read the tagline.
I've been practicing. All right. Remember to be skeptical of anything you learn, even if you heard it on the Skeptic's Guide to Emergency Medicine.